Hello everyone, my name is Hung Lee. I'm the ID pharmacy resident. Today the topic is pharmacotherapy of the candidemia in the adults. Candidemia is a topic that everyone knows a lot, so it's just like more of the review and the Martin and College in an article published in the New England Journal of the Medicine look into the epidemiology of the sepsis in the United States from the 1979 to the 2000, and they look into the trends, not only that the trend increase in the bacterial infection, but also for the fungal infections during the 22 years. The fungal infection rate had been increased to 200%. And at almost the same time, Edmond and College look into the nosocomial bloodstream infection in the United States hospital for the 3 years analysis. And they found this Candida species cause infection in the hospital, ranked number 4, and with the mortality rate is really high. It's about 40%. And how about currently? That's the data that were before the 2001. Currently, the Fabler and College look into the invasive fungal pathogen to see the trends, and they found that the infection with the Candida, glabrata, Aspergillus, and non-Aspergillus appear to be on the rise. And they look into the past, and they found that the Candida account for the 42% of the fungal infection, whereas the Aspergillus about 27%. So these two species account for more than 70% of the fungal infection in the hospital. So what causes it? So Nusi and College look into the reason for why we have more fungal infection in the hospital, and these are the reason because there's in the past 20 years there's an increase of number of the patients who are at risk. Patient with solid organ transplants, patient with hematopoietic stem cell transplantation, cancer, the patient received chemotherapy, more population patient with AIDS had been increased, premature birth, advanced age, and more the patient with major surgery. For the Candida infections, so the risk factor for the Candida infections, according to Ostrowski and College, in 2006, they think that the patient who has Candida colonization in the multiple sites who are actually at the high risk. A patient who has abdominal surgery, especially with the GERD1 transected, can be at high risk. Patient with the central vascular line, patient on the major or the broad spectrum antibiotics, the patient with the TPN, and the patient will stay in the hospital longer than 10 days. For the non-ICU patient, especially usually the cancer patients, the patient who has a prolonged neutropenia or the severe mucositis, and the major port entry, usually the GI. Patient with the colonization more other than like Candida albicans. At Nusi, in his study, he questioned about the role of the central indwelling catheter, whether it's a sort of the infection or not. So in order to help to diagnose the patient with actually with the high risk with the fungal infections, Ostrowski came up with some of the criteria. There are the two major criteria and some of the minor criteria. The major criteria is either a patient on the systemic antibiotic from day one at least, or like 1 to 2 to 3 days, or the present with the central venous catheter at least the same 1 to 3 days, and plus with two of the following. There's many that, and for some reason they didn't come up with it. A patient actually with previously on the corticosteroid, patient on the receive the chemotherapy, patient were on the have a surgery past 7 days, and with the new criteria, they with Ostrowski in his study, they captured about 1/3 of the case in the units. And Papas and Collis in his study, prospective observational study of the Candida in the hospital, and they found that the highest, the most common species that cause in fact Candida infection is actually the Candida albicans with 46%. The next in line 20%. The third one is parasclerosis. The fourth is tropicalis. The next one Crucei, and the last one is the Lusitanis. These 6 species account for more than the 93% of the Candida infection in the hospital, according to his study. So what the antifungal infection that we have in for the Candidemia. This slide shows you the timeline of the development of the antifungal agents from the early of the 1950. We have Ampho-B, then the flucytosine, ketoconazole, and up to the 90s, then we start having the fluconazole, itraconazole, and some the lipid base of the Ampho-B. After 2000, we start having more and more the antifungal agents, carfofungin, voriconazole, micafungin, anidulafungin, posaconazole. There's isovuconazole is on right now. It's at the phase 3 clinical trial. Maybe we might see it in next. Maybe get approval. Maybe it might be get approval sometime soon. Rasuvoconazole had the phase 2 clinical trial had been done in the 2000. It's been 8 years. I don't know what happened, but that's why the question mark is about. We don't know whether we can have this one or not. So the antifungal agent for the Candidemias actually available is for the Polyene, triazone, and I break down that this is the triazone for the called the oazone, fluconazole, itraconazole, and the new one called the extended spectrum triazone, voriconazole, posaconazole, and Echinocandin. Flucytosine, it has some activity against the Candida, but more the literature that they don't when they recommend the treatment, they don't mention the flucytosine. For the mechanism of actions, we look into the azole has something interaction. Well, that's the main effect is on the ergosterone synthesis pathway, whereas the polyenes acts on the ergosterone on the fungal membrane, and the echinocandin acts on the beta-1,3 glucan synthase that weakens the cell wall of the fungal cell wall. Let's look into the polyenes. The mechanism of polyenes are the Ampho-B. The Ampho-B is binding to the ergosterone of the fungal cell membranes, the yellow one. And when it binds to the ergosterone, it can cause a depolarization of the membrane and forming the pores and cause the leakage. The polyenes that we in the past we have the conventional one is the amphoB deoxycholate. It has a no limiting the renal toxicity. Usually you will see the abnormal the electrolytes when the patient go into the renal toxicity. We have with this medication we had the infusion related reactions. Also the efficacy is very limited to the severe immune suppressed patients. The newer agent, the newer formulation, the lipid formulation of amphoB, the newest liposomal amphoB, the amphoB, the lipid complex, and the amphoB colloid dispersions. It has a less renal toxicity compared to the amphoB. However, the systemic toxicity is still somehow, when you compare between the D3, the liposome of amphoB is the least. And the high dose of the amphoB usually will increase the renal and the liver toxicity, and later on of this presentation I will show you that there's a study show that the higher dose is not really effective compared to the lower dose. So the amphoB, the toxicity, Bates and colleagues in 2001 looked into the study of the 707 patients received amphoB in this 4 years, and they found that 212 patients account for the 30% of patients actually have had the acute renal failure. And the mortality rate of this group, the patient who has the acute renal failure, actually the 54% versus the one who didn't have acute renal failure, that's 16%, and adjusted odds of that is 6.6. The cost, the length of the hospital stay increased, so our average is 8.2 days more longer, and additional cost is about 30,000. But this is the cost of the 2001, so we don't know that whether we can translate to the cost for today. For the lipid formulation of the amphoB, it has the same broad spectrum as the parent compound, less toxic compared to the amphoB, the oxycolate. Generally, it's well tolerated and has been evaluated extensively. Connolly and colleagues in 2005 conducted a trial called the AMBILOT trial, compared the liposomal amphoB 3 mg versus the 10 mg per kilogram a day for 2 weeks, and found that both regimens had similar efficacy. However, the higher dose actually increased the hepatic and the renal toxicity. Let's go to the next class, azole. The azole actually binds to the ergosterone synthesis pathway, so it interrupts the synthesis of ergosterone. And when it interrupts it, it causes the depletion of the ergosterone and also causes the accumulation of the toxic intermediate sterone. You see that there's a combination between the use of the azole and the amphoB. So the amphoB, we know that it binds to the ergosterone. So if we use the azole, we have to use the combination. So we should use the amphoB first, because when it binds to the ergosterone, if we use the azole first, it will cause the depletion of the ergosterone. Then when we add the amphoB in, the effectiveness will be lower. The oldest triazole that we have is the fluconazole. The usually dose for the Candidemia is the 400 to 800 milligram. Very commonly used. Advantage: it lacks the toxicity, a good bioavailability, and they have active against many candida species. The weakness is it has a variable activity against with Candida glabrata. It has a narrow spectrum. Doesn't have activity against Aspergillus. Usually often the underdose, and it has poor outcome compared to the echinocandins. And these drugs they always has a lot of drug interaction because the cytochrome 3A4, 2C9, 1C9. Yes, sir. Yes, sir. Yes. Yes, sir. And that's why many the authors recently when they look into the use of the fluconazole today um, for the carbada, and usually they recommend that either use of echinocandins or the high dose of amphob. And fluconazole is now recommended for the non-neutropenic or the stable patients, and they shifted the use of the echinocandin to the for the patient with unstable and or the neutropenic. Uh, and the role of the fluconazole in the paraspherosis is questionable. Some articles said that yes, we can still use it, but some said it's not good because the embassy of the paraspherosis for the fluconazole have been increased. So I'm not sure about that because right now it's kind of controversial. So I would like to have an input of the Dr. Green and then Dr. Ayler and everyone by the end of this presentation. Yes, sir. The itraconazones, the usual dose is 400 to 600 milligram a day for PO and 200 milligram a day for IV. But it has been noted that when you look into the guidelines, you still see that because the IV, but the manufacturers already discontinued the IV formulation, so the IV formulation is not available. The reason is the manufacturers state that the marketing reason, so we don't know, maybe they don't sell it well. Considered as a second line for the aspergillosis therapy, and it has a limited efficacy data for the IV form. That's the reason. And the PO form has a taste disturbance and suspension. Usually the liquid form usually to improve the bioavailability. It has a GI toxicity, and we should avoid the IV. Of course, now we don't use IV, so this is not the reason why we don't need we don't have it, so we don't have to concern about the reason why we avoid using the itraconazole in the patient with the renal function less than 30 for his clearance.
I'm also not fond of the fact that warning about cardiotoxicity of itraconazole. It's the only azole that's ever been reported to cause CHF.
Oh, yes.
So it's kind of
The voriconazole is one of the two the extended spectrum the triazoles available in the IV and the PO form. Usually the side effect of the most people complain of the visual, hepatic, or the skin toxicity. So I got one patient at the clinic and said that he got a vivid dream, but it's not really scary, but he liked it. So I don't know what kind of dream he got, but he liked it. It also had the drug interaction, not much at like fluconazole, but they had the drug interaction because the cytochrome P450 considers now at first line therapy for invasive aspergillosis. Especially there's a new guideline that came out earlier of this year. Also, this voriconazole also effective in the fusarium pseudosporium, but not on the zygomyces. And the IV formulation should be avoided in the patient with the creatinine clearance less than 50, because the IV vehicle is called the symphobutol ethyl beta cyclodextrin can be accumulated in the and can cause more the renal failure. Uh,
associated with the accumulation of cyclodextrins. I mean, I know in rats, tubules, you can see that there's collections in there.
I'm not sure that, like I've seen it, but I didn't see the, like, any report. But the manufacturers recommended not to use it. So when the patient had the renal function down to like under 50, usually we try to switch to the PO. But at the VA, usually the population is old, and most of the patients in the unit they have a bad renal function already. So when we put him on the voriconazole IV, there's creatinine clearance about like a 55, 60, and when it goes like it gets worsening, then we have to like switch to the PO, and too bad the patient already have trach. So, and it's really hard to do the voriconazole IV in the old population with the bad renal function. I don't know that, like, if you've seen anything that.
Versus benefit. I mean, I've given it to people with insufficiency. IV XPO wasn't an option for them.
Mm.
Just monitor them. I mean, it's you take a theoretical risk of nephrotoxicity versus a known risk of nephrotoxicity.
Yeah.
Which one are you going to put on?
I guess that's not a question.
I mean, you have a few other options. You got a pretty clear-cut case of asthma.
Uh, the Kubas and college in 2005 looked into the voriconazole versus the regimen of the amphobi IV, and a follow with the PO fluconazole for the candidemia in the non-neutropenic patients. And he found that there was a similar efficacy between the two regimens. Both regimens can clear the blood within 2 days. The side effects, when compared, they said that they look into this. They said that the cause of the side effect that leads to the discontinuation is more with fluconazole or voriconazole arm than the other, and the toxicity usually, of course, it's more with amphobi and fluconazole arm, and they said that it's better toleration with voriconazole. So this study, the Colbert and Collett recommend that you use the voriconazole at IV for initial therapy, and use the PO form for when the patient is stable at the step-down therapy. There's another clinical trial, one is Spelbert 2006, and he said that there's an azole growth resistance in the candida can occur, especially with the fluconazole resistant candida glabrata. And so he questioned about the effectiveness of the voriconazole, and he recommended that Echinocandin or high-dose Polyene should be referred for the candida glabrata or crucii. Panaco and College published another article in 2006, but at the end of 2006, and he found that for the candida glabrata, there's a significant association between the MIC of the voriconazole and the fluconazole and itraconazole. It means that if the MIC of the fluconazole is higher, then the chance of the MIC of the voriconazole is going to be higher. So he said that there's a significant cross resistance between the older azole and the newer azole, voriconazole, in the candida glabrata. So that's why he gives advice that the caution should be used we should be advised that should not be used voriconazole in the sick brother with the patient that have a prior exposure to the azole.
At least until you get your MIC data back, right?
Mm-hmm. Say,
Right.
the latest one is the posaconazole, only available in the PO formulations. So the PO availability is increased with the high fat meals, well tolerated in the clinical trials, and there's only two clinical trials, and they said that they want to use the posaconazole as salvage therapy for invasive mycosis. This study looked into the posaconazole versus the fluconazole or the itraconazole prophylaxis in the patient with neutropenia. And in this study, they found that the mortality rate is lower with the posaconazole arms compared to the arm with the fluconazole or the itraconazole. And it also look into the survival rate, and the survival rate is had been for the posaconazole arm is better compared to the fluconazole and itraconazole. But that's it after about more than 3 months. The last class of the antifungal Echinocandin. Echinocandin actually binds to the beta 1,3 glucan synthase, so it weakens the cell wall, and when the cell wall weakens, so it cannot withstand the osmotic stress. We have only the echinocandins, the caspofungin, micafungin, and anidulafungin. It has the rapid fungicidal for the candida, and all of them available in the IV form only, and it has a minimal renal toxicity, actually mainly to metabolite to the liver. It has activity against most the yeast, candida and candida albicans and non-albicans, with most aspergillus but not Zygomyces. So caspofungin is loaded dose is 70 milligram, and then 50 milligram a day. Very well tolerated, and it have potential drug interaction with cyclosporine. We need to have a dose reduction in the hepatic function. D2 that has similar efficacy versus the amphob in the invasive candidiasis, and we'll see this. This is the study. Mora Duarte look into the compare the caspofungin with the amphob for the invasive candidiasis, and he looked into that, and he compared that when he used a modified intention to treat analysis, so included all the patient in the study. He found that there's a similar efficacy between the two arms, 73% with the caspofungin and 61.7 is not really statistically significant. And also, at the end of all the antifungal therapy, we'll see that there's no difference between two arms. However, if they excluded on the patient that didn't follow through on the therapy, they found that there's a significant difference between the caspofungin arm and amphob, and caspofungin is better. But that's not the way we conduct the study, because we have to use intention to treat. Micafungins are available in IV. The dose is between the 50 to the 150 milligram, well tolerated, approved for the prophylaxis in the high-risk patients, such as the hematopoietic stem cell transplant, and we use it to treat a patient with Candidemia, esophageal candidiasis, and systemic candidiasis. We look into the course and look into the conduct a study, compare the mica function versus the liposomal amphotericin B, and he found that there's no statistical difference between the two arms. Amphotericin C, mica function is not inferior compared to the liposomal amphotericin B. And at the end of by the end of the therapy, they look into the failure rate, and they look into the candida albicans. The both arms are almost like the same, 11%. And they look into the parasimplosis, glabrata, Gusei, and they also had a similar failure rate. If the number is look like it's lower, but they are not statistical significant. And they also look into the other than those are listed, the candida species that not listed, and look similar failure rate. Pappas and colleagues in 2007 conduct another study compared the mica function versus the kappa function. This study have three arms: mica function 100 mg per day and 150 mg per day, and versus the kappa function the 70 mg floating dose and then 50 mg a day. And they found that there's no difference in the mortality rate, no the relapse, emergence of the infection, and adverse events. And the cultures negativity that show that 2 days later, mica function arms 100 mg a day arm and kappa function, whereas the mica function 150 mg a day clear the blood after 3 days. So the dose of 150 might not be as good as the 100, or maybe at the same. The last drug is Erasys or the Anidulafungin. The loading dose is 200 mg, then maintenance dose is 100 mg, well tolerated, and the spectrum similar to the other Echinocandin. Gross and College in 2004 conducted a study and found that the efficacy of the treatment, they have some efficacy in the treatment of the esophageal candidiasis. Ribole 2007, and found that Anidulafungin is superior than the fluconazole. Anidulafungin is a very quite unique antifungal agent because it for the patient with hepatic impairment, you don't need dosage adjustment. The patient with the renal impairment, you don't need dosage adjustment, and not clinical relevant to substrate or inducer and inhibitor of the cytochrome P450, so you don't have to worry about the drug interaction, because these drugs, they undergo the chemical degradation in the pH and temperature, the body temperature, so it deactivates by cell. This is a study like I just mentioned before by Cross in 2004, compared the Anidulafungin versus fluconazole in the treatment esophageal candidiasis. And they compared the two arms, and they found that clinical success and also the mycological success was similar between the two arms. And these two, they look into the time of the resolution of the symptoms of both arms have the average of 5 days, and also the duration of the therapy, the median of the patient stay in the hospital, they both similar 14 days. So the IV, the Anidulafungin, is not the superior or compared to the oral fluconazole in the treatment. And they also look into the patient adverse event to see to compare the both arms. And you see that over here, that's adverse events, they are very similar, the same rate. The last study is the Anidulafungin versus the fluconazole in the invasive candidiasis. In this study, they look into they compared between the two arms, and they found that they have for the Anidulafungin, actually it have a better efficacy compared to the fluconazole in the treatment of invasive candidiasis. And survival rate in this study is Anidulafungin actually is not different compared to the fluconazole with the P's of less than more than 0.05. This is the recap of the antifungal sensitivity against some of the candida species according to the Fowler and College, published in the CID 2006. You see this for the Robrata still have a lower activity, have sensitivity is low compared for the amphobe, flucytosine, fluconazole, itraconazole, posaconazole, and even with the voriconazole, it's kind of low compared to the other candida species. And of course, for the cruceae, we have almost no activity against with fluconazole. Doss and Azole in 2006 have a more comprehensive look into the spectrum of the antifungal, and you see that the fluconazole have some only the activity mostly with candida. Of course, it's not with the cruceae and Robrata. For the extended spectrum, the triazone, the voriconazole, and posaconazole, these two drugs have a good activity against like candidas and aspergillus species. Echinocandin also has a good activity against the aspergillus and candidas. With one exception that for this study they said that for the parasimplosis maybe the candida echinocandins may have some weak activity against this candida, this species. Yes.
Yeah. You showed in an earlier slide that ambisome and I think it was Mycofungin had the same, actually had similar efficacy against Candida parasimplosis. We see the same.
With
I think it's interesting. Candida parasimplosis is the one that breaks through the disease. Look at the comparative head-to-head trial. You look at those subgroups. They don't look like in their response rates compared to alternative agents.
That's what all the you can't we have had some breakthrough
Hmm.
for the most part.
I don't think you can say that ambisome, for example, is better for Candida parasimplosis. It's just a breakthrough. Candida parasimplosis can be problem bugs.
I liked your graph because Cedosporium prolificans, there was negatives all across the board.
Yes.
Except for azoles plus minus second.
Yes.
Actually, that's a very nice thing to have.
Is it within Stanford?
No, it's not.
Stanford hasn't reached.
Stanford got negative.
Yeah, they had updated.
This is in the CID 2006.
Is there any individual fungi? Are they using it?
About all the drug interactions. They thought that it was less liver toxic than all the other agents. Some kind of fungal coverage. They didn't want to give them
continue. We're looking to the C. Candida cruciae is have intrinsically resistant to fluconazole because itself it have the decreased susceptibility of the 14 alpha demethylase cytochrome P450, so it decreased the effect of inhibitory of the fluconazole. So the testing in the vitro offer no beneficial information. So it's also according to the Alexandra and College in 2006 said that also have a cruciae also have a decrease susceptible to the beta amphob and also flucytosine, and they still are susceptible to voriconazole, posaconazole, and echinocandin. For the Crabrata, still susceptibility to the fluconazole varies significantly because this species of this species increase the drug efflux, so pump the blood the fluconazole out, so we can overcome it by using the high dose of the fluconazole. They're the cross resistant and with older azole drug like fluconazole or the itraconazole with the voriconazole, and also it has a delayed killing effect with the amphob. So with amphob, usually they recommend to use a higher dose, and still susceptible to the echinocandin. For the parasitolosis, is susceptible to more the antifungal. More Duarte look into the 2002 look into the compare the carbofungin and the PharmD, and they found that both the agent had similar efficacy for the parasitolosis. And Spellberg and College in 2006 and look into the echinocandin and in vitro. It seems that the higher MIC for this Candida species. So whether it has some clinical relevance into the for the therapy or not is still unknown. The last Candida species that we want to talk today is Lusitania. It's resistant to the amphob and still susceptible to the azole and echinocandin. So I just want to bring up a few things that recently that when I attended to the many lectures recently, we talk about empiric therapy and preemptive strategy. Morales and College in 2005 look into the delay of empiric treatment of the Candida bloodstream infection, and they found that if there's a delay in the antifungal treatment hour from the blood draw within. So we'll see that if the delay after 12 hours later up to more than 2 days, the mortality rate has been increased about 3 times from that around 12% up to the 30 to 35%. There's another similar study, the time to initiation of the fluconazole therapy, whether it impacts on the mortality rate of the patient with the Candidemia. And in this study, they found similarly, if the treatment started on the same culture day, the mortality rate tend to be lower, only 50%, whereas the therapy, the treatment started later on, day 1, 2, or 3, the mortality rate tend to be going up. So for the morale, he said that the time is very essential in the treatment of the Candidemia. So the delay of the effective treatment in the severely ill patient, usually the impact have a high mortality rate, especially with Candida or Aspergillus. So there's he also mentioned about pro and con of the empiric use of the antifungal. Pro is because the high mortality rate has been proved, and difficulty in the early diagnosis and the undetected infection. The con is they said that because sometimes the patient might not have a the fungal infection, so that may be over the treatment that leads to the unnecessary cost and also the safety. We have to use a different antifungal drug that may have renal or hepatic toxicity. Also, the threat of resistance might be developed. So, but many people still advocate for the use of the preemptive strategy because it reduces mortality rate. But does have a problem with the early detection and treatment. And they use a new diagnostic approaches how to screen out the high risk patients. So they identify the high risk patient for the invasive fungal infections. So right now with the fungal culture it takes about 3 days to get the cultures back for, so they will want to use like some non-culture based methods such as the radiology, histopathology, cytology, or the serum assay. Mainly there are the three tests right now. The beta D glucan detect the cell one component very specific of Candida, Aspergillus, Fusarium. The enzymatic assay Confungitel, I tried to get the price on this test. I couldn't get it because for some reason it talked about Fungitel but didn't say much about the cost, actually cost.
We don't have that available here often, do we? We do not.
Galatomanins.
Cultures back. And the other thing that Papa said about that test, if I'm not mistaken, was that you have to be careful with people with abdominal surgery with a lot of gauze in their wound because I guess there's a component of that in the gauze. Positive galactomanins that we can't find the source for. Negative. Makes me uncomfortable and
The, s- the second test is galatomanins, mainly for to detect the Aspergillus through the polysaccharide component in their cell wall. The have a form can have a false positive because when the patient on the zosine. And the most tests that have been reliable up to now is the PCR assay to detect the fungal DNA. And according to Patterson and College and also in Cambridge, and they said that the sensitivity highest is the PCR, only 79%. The beta glucan and only the 67, and galatomannan is lower, 58%. The combination, they recommend the combination of the glucan test and galatomannan can give you to the 100 positive predictive value. So it's not really highly sensitive, but the highest value is at 79, so it can be lower.
I wouldn't start ordering it willy-nilly, but I've got a couple people who have these positive galactomanins, multiple positive galactomanins, and we work them up, and we've got no source for like an aspergillus infection. It would be interesting to order.
And this is the last slide. I set like a reminder of the 2004 treatment guideline for the Candidemia in the patient with the neutropenia. I just bring up because we see the more with the patient neutropenia. So this is the standard dose that we see. The start that I put over here, these are the Anidulafungin, voriconazole, micafungin, for example. These are have been used after the guideline published. It's not in the guideline if you look, and I believe that everyone very familiar with the guidelines, so I don't need to repeat it.